Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello, and welcome to another one of our 5 Slides We're Discussing virtual conversations. We've been hosting these in this COVID space, trying to continue to foster conversation and foster community about topics and issues that are either geographically specific, demographically specific. But in every case, what we do is, here at State of Reform is try to create a multi-silo perspective. And certainly that's what we have lined up today as we explore the impact of COVID and how the healthcare silos, the healthcare sector is responding to those pressures and challenges of COVID in the state of Arizona. So I want to jump right in with introductions of our panelists. But before I do, I want to also talk through a little bit of our kind of the ground rules and what you can expect participating today. We've got a little over 120 folks registered to be with us. And what we want these to be are interactive engagements, conversations where you can chime in as well. I know people come and go from virtual conversations. They're here for 10 minutes and they may be gone for 10 minutes and back later. But when you have questions, you'll see on your screen there's a Q&A tab. Feel free to just chime in there and tell us what you're thinking. You can upvote when you see other people with questions that you think are worth being asked. When you upvote those, that tells me that other people think those are interesting, and I can just try to address those to our panelists as we speak. So sometimes those may be a little bit belated, meaning we may have moved on from the conversation a little bit. That's okay. Upvote them anyway, and I can try to draw them back into our discussion. So without further ado, let's jump into our panelists. First, from MercyCare, we've got Lorry Bottrill, President and CEO. Lorry, thank you for being with us.
Thank you. Always enjoy being part of this, and such an important time to be having this conversation. Real quickly, MercyCare, as you may know, is a large Medicaid plan here in Arizona, so serving lots of different populations, and really excited to be part of the Arizona conversation. So thank you.
Yeah, thank you. Mo Sheldon comes to us as CEO of Northern Cochise, Cochise, it's Cochise, right? Community Hospital. Thank you, Mo, for being with us. I appreciate it.
Thanks for having me.
Yeah, and Marcus Johnson, the Director of Health Policy at the Vitalyst Health Foundation. Marcus, thank you for being here with us.
Thanks a lot for having us. Happy to be here.
Yeah, appreciate all you guys doing this. And as the panelists know, and as our attendees know, this is our third 5 slides discussion. So you're all guinea pigs. Thanks for working through this with us. Marcus, tell us a little bit, just to start, tell us about the Vitalyst Health Foundation and the kind of work that you are engaged in there.
Sure, yeah. So Vitalyst Health Foundation is a funder by trade. We're a medium-sized philanthropy. Been around since 1996. We're a conversion foundation based off of the sale of a hospital here in the Valley. We kind of grew up really focused on healthcare in a traditional mindset, trying to fund medical services, trying to fund vehicles to make sure that we could transport people to hospitals. But we've grown up, and we've grown our mindset about what health really is over the years. And so these days, we still have a strong focus on access to care and access to health insurance coverage, but we're also really venturing out and trying to improve the housing system, food systems, transportation systems, those social determinants that actually provide the foundation from which we can all be healthy.
Yeah, good stuff. Mo, tell us about your hospital. You're relatively new to Arizona here in the last 2 months, taking that position. It's a centrally important institution in your rural community. Tell us about the work you're doing at your hospital.
Sure, thanks. So we are a small critical access hospital in Willcox, Arizona. We serve our immediate community is about 3,500 people. Rest of our primary service area, about 5,000 or in total for 5,000. And then an additional 5,000 people or so in our secondary service area. And we provide primary care, and as a hospital, our emergency room is probably one of the biggest areas we serve around 450 patients a month in the emergency room. Our payer mix is largely a pretty equal mix of older adults, insured patients, and financially challenged patients with Medicaid. So,
yeah, good
gotta-
stuff. Yeah, I'll spend a little moment on this here in a second, but I think it's great that you're with us, Mo. I think that the rural hospital experience is one that often gets overlooked, but it's centrally important for a lot of our geographies, and it's just kind of unique to have a critical access hospital, a philanthropic organization, and then a major health plan that's really been on the cutting edge of a lot of innovations in the country. So, Lorry, tell us a little bit about MercyCare and the work you're doing, have been doing, and a little bit about the role you play in Arizona's healthcare system.
Sure. So as I mentioned, MercyCare is a large Medicaid plan here in Arizona, but some of the unique things we're able to support Maricopa County Regional Behavioral Health Authority with that contract. And so we manage the entire crisis system for Maricopa County. So as we've been working through COVID and all kinds of things, really present some unique challenges as a health plan as well. But we're really committed to, the justice system, individuals involved in the justice system, housing, kind of all the things in partnership with Vitalyst and other organizations that as we evolve our thinking of healthcare. So I'm really happy to be involved in these conversations and really realize as a community, we're really making a difference. So thank you for having me.
Yeah, you bet. I want to jump right in to our first slide. For folks who are just engaging with us, we ask our three panelists to each bring a slide that is a graphic illustration of something they're spending their mental energy on. I tee us off with the first slide. So this is one I've brought. I think all of us are spending mental energy and emotional energy on just trying to grapple with the protests of the last 8-9 days, depending on one's community. The deaths that spurred those, and of course the chaos wrought by a very small group that threatens, I think, the meaningful protests of the communities that are now rising up. So this was a shot from Phoenix. I took a screen grab. I thought this was a compelling case of what was happening downtown Phoenix in the last few days. I think this was Sunday. Lorry, let me ask you first. How are you thinking about these protests and the uprisings across the country? How are you thinking about them both personally, but how do you think MercyCare can respond to them?
Yeah, so such an important topic and something I'm sure as other leaders as well just spent incredible amount of kind of emotional and mental time, certainly over the last week, trying to listen, learn, be reflective of both personally what I can do, and then additionally, as you mentioned, what can we do as MercyCare? How can we impact not only our colleagues, but those in the community? So really just right now in more of a really learning, listening, reflecting time period, but certainly pretty quickly want to really think about the health equities, inclusion, training, things that we do today, but how do we take it to that next level, and how do we partner with the community and other leaders to really make meaningful change and not have this be 8 or 9 days, but how we live going forward and make some meaningful, and impactful change. And we know we've had, things come up here locally as well. So it's not just somewhere else in Minnesota and other places, it's real in Arizona as well. And something we all need to pay attention to as well. So Thank you.
Mo, how do you sort of wrestle with these being in rural Arizona? The population is obviously usually more diverse in cities and urban centers. How do you think about race relations as a CEO of one of the most important institutions in your community?
Yeah, these demonstrations are moving into the rural areas. In fact, I received an email just not long before we started here today about the rural areas in our county that will be experiencing some of these folks to really demonstrate about what their beliefs are. And I think we, as healthcare providers, need to focus on the same things that Lorry was discussing. We need to work with our teams to make sure that there is appropriate education and that our patients feel equal all the time when we serve our patients, and then look further. I think it's our responsibility in the community to look further into the community and to look at how we can help other community organizations develop plans to move forward with health equity.
Yeah, Marcus, I used to teach at the community college level and at the university on occasion, and I would from time to time try to create a safe table, much like we try at State of Reform, but a safe table for my students to talk about race. And what I found at that community college level was that really very, very, very few people, even at that stage of their life, had the tools to talk about race. They didn't really have a vocabulary. They didn't know what was safe and what wasn't. They didn't understand what might be offensive and what might not be. Mm-hmm. It strikes me that we don't really have a vocabulary yet, and we don't really know what the ground rules are. How are you thinking about supporting conversation as an individual? How is Vitalyst thinking about supporting these kinds of conversations? What are your thoughts there?
Yeah, I mean, it's a great question. As a person, like I'm inclined to be someone who's pretty data oriented and action oriented. When I walk into some of these conversations, I'm thinking, what are we going to do about this? Let's get a plan together. Let's figure out some solutions. And our experience with Vitalyst is that work needs to happen, but the true work that needs to happen first is internally. And DJ, to your point about being able to find the language, find ways to actually have these conversations is a really, really difficult thing to do. And so at our foundation, we've done our best. We're definitely not perfect, but we've done our best to kind of carve out space to hold those conversations. We allow any of our colleagues to have counseling services, to be able to talk to people if they need to. We've actually had team meetings where we talk about race, where we talk about, we find safe spaces and talk about our own individual experiences. We talk about the experience of our foundation as a whole, that's been around for some 25 years, and has always been kind of dedicated to decreasing health disparities that are out there, but we've never really taken a racial lens to that. And so what does that mean for us as individuals? What does that mean for us as an organization? And how can we help to really live up to the value of equity that we actually center within our values? I was recently on a webinar where a pastor, Pastor Warren Stewart, who's with the First Institutional Baptist Church in South Phoenix, he's one of the leading African-American folks in the Valley. And he was talking about acknowledging the pain that's out there, acknowledging the fact that there is anguish, there is frustration, there's exhaustion, right? For the African-American community and for communities of color, this is not new to us. Like, we get this, we've dealt with this in our entire lives. We're ready to see a change. His quote, and I want to read this, he said, and I thought this was pretty powerful. He said, "This is a problem created by white power structures." And I thought, you know what, I think that's straight and to the point, but it forces the systems that we operate in to start looking internally, to look at, when we have a hospital or a large institution, we have photos of all the leaders from all the years on our walls. And if you don't see any people of color on that wall, ask why. Why is that? And then you can really start having those difficult conversations as individuals and as organizations, and hopefully move towards solutions.
Yeah, the healthcare sector is a little wider, a little more highly educated, particularly amongst the professional physicians and providers, more highly educated, more white than the economy and the population as a whole. Just sticking with this for a second, Lorry, how should we see the healthcare sector within this broader conversation? I mean, we all have to lead through this individually and as organizations. One of the central challenges, and to Marcus's point about sort of white power structures, tied into that are structures of income inequality and how they, as that gap widens, it makes it difficult to go from one economic class to another. How should we think about those challenges in healthcare? It seems like in the Medicaid space, you are dealing with people of color, you're dealing with people of lower economic means and at the safety net. Does this catalyze a time for a Medicaid for all conversation? Does it catalyze a time for a Medicare for all conversation where healthcare may be less of a problem for folks to move from one economic step to another? It's a big question. How does healthcare fit into this conversation, you think?
Yeah, I think it's a great question and something we've been thinking about even in the last week or two to really think, we're a Medicaid health plan, but this is something that impacts our colleagues, our members, our providers, our community. And I like the way Marcus mentioned that earlier, which is we look at health disparities, health inequities, inclusion, especially language or, kind of zip code analysis and things like that. But what we haven't done is really had that racial lens that we really spent time on. And so I think for us, this really gives us a new way to think about things that we probably shied away from or stayed away from in a way that we shouldn't. And so to me, this will just be a new way of thinking about things and a new lens that we just really need to focus on. So for me, I'm really excited about not only starting today with this conversation, but looking forward to many more going forward.
Yeah. With that, let's segue to our next slide, which is a slide that you've brought, Lori.
Sure.
One of the great stories, or the most compelling stories, I guess, out of the COVID experience and healthcare's response is the implementation and expansion of telehealth. Tell us what you got on this panel, or on this slide, rather.
Sure. So in the graph, really just looking at MercyCare data, knowing that it's not even fully complete necessarily, but what's been striking for us is clearly the increase in the telehealth. So we know for all of us in the healthcare world, we've thought it made sense. We, understood that telehealth, we've had tools out there and rolled things out. I know within MercyCare, we've rolled things out over the years and seen very low participation with it. Maybe even people sign up, but they never use the services or never find that's the way to do it. And so interesting in this time, how quickly we were able to ramp that up, knowing that March even includes, probably half of a month where, people are still out getting care. But certainly by April, you can see in that top blue section how significant the change has been with telehealth. So, and when I say telehealth, it's kind of all tele services. So it could even be just telephonic, right? We know that we're all, especially in this crisis, really just trying to make sure we are engaging care, and really have just had some amazing stories as I listen to both physicians, parents, members, really some real great feedback. So we did it because there was a need and it kind of shifted that culture. It'll be interesting. And we certainly would expect it to have lasting impact, whether it will be at this level or it will be something in between. We certainly absolutely support it as MercyCare. As I mentioned, I've been in lots of different forums where I've gotten some great feedback of parents and others saying, please don't make me have to go and drive all the way downtown or get in a cab and take my child there and, get in the parking lot. It's hot, all this stuff, to really do something that could be done almost effectively, on my computer screen or on my phone. So really some amazing feedback. And like I said, from all aspects. While that said, and while we're really excited that, there seemed to be great engagement during a time where it was really needed, and we were able to use some things and put things in place, really quickly. We also recognize it's not perfect, right? So for some individuals, I'm not comfortable on the phone, or I don't want to do that. And we know that. And also technology isn't the same for everyone, especially if you think about rural areas. Is technology always, or depending on individuals' comfort level with that? I don't want to talk into a computer screen, or I'm not comfortable with that. We absolutely know that. And what we don't want is to make it so far the other way that we don't take time to realize there's certainly value in that, person-to-person visit. And there's certain services that need to be done in person. but how do we find a way? And so as I think about future thinking, for us, it's, this has been kind of a flip all the way one way, so where's that right middle, or where's the right way to do this going forward, and that we create, really meaningful engagement and maybe more comfort and kind of culture change, that it's okay to get televisits, and that, works just as well, but then not forget that it's not one for all, right? Some people want it, or some situations we know are going to result in really wanting kind of that person to person interaction. So for us, it's just kind of such an amazing change. And what I noted in here too, where you can also see is even ambulance and non-emergent transportation actually went down a little bit. So what we see is not having to use those services while you're able to engage with tele. And probably the main area we've heard it the most is on the behavioral health side, just some really great engagement where we didn't know that maybe even that was possible. So with that, that's what I have for that, but really excited about how this may change our delivery system going forward, but want to be cautious and mindful as we move it forward.
So good stuff. Mo, tell me, from the view of a rural provider, where you've already had a telehealth component, I assume, for a long time because of the nature of providing care in a rural setting. Is this a catalytic moment for things that you're already doing? Or is it more of a paradigm shift so that you're doing things in a way that you really would not have expected maybe 6 months ago? How would you respond there?
So it'll be interesting to see. We have not here done very much in the way of telehealth previously. Our rural patients still come to see our primary care practitioners, for instance. But I will say that in the month of April, 17% of our visits in primary care were telehealth visits. And in May, it came down to 3%. So, that may just be an anomaly, or as the virus changes, the telehealth component may change as well. For us, the rules were relaxed by Medicare in particular with respect to being able to do telehealth visits. And there were a number of rules that were relaxed that allowed us and other providers to be able to do things differently than we'd done them in the past. And a lot of how that moves forward in the future is going to depend on the federal environment and how they envision moving things forward. And I think we certainly would want to contribute to that conversation. I do think there's definitely a place for telehealth visits. And I agree with Lori, there's very much a place still for in-person visits, but for people who do have transportation challenges or other concerns, we would like to be able to keep this in place.
Let me ask one follow-up there, Mo. One of the rules changes you mentioned is the allowance for providers to bill for audio-only telehealth services that does not include a video component. Is that an important thing for you all to try to maintain moving forward?
I'd like to be able to enhance it. What we have been doing is primarily the audio-only visits. I think in the future, I believe there's more of a connection between a patient and a provider when they can visit visually as well. And for those patients who would prefer a telephonic visit, I think that's great too. But I think there's something that goes away from that connection with the provider, and the provider being able to see their patient. It makes a difference. Yeah, and it makes a difference for patients.
I want to make sure that we can include your questions from our audience members who are participating. And Len Kirshner has one. Says, much of the media coverage is COVID in the nursing home setting. Little is focused on the assisted living or the group home or HCBS clients. What are you seeing in these populations? Any lessons that might be different from what we're seeing in the mainstream media? I'll open that to anybody who'd like to take a crack based on the way that you engage on that topic.
Yeah, and this is Lori. I can start for our all-tax population, certainly something we're very focused on. I think we've seen a fairly similar approach taken where for us, we have care managers. We're used to going and meeting with our members on a quarterly basis and really having that connection, and have had to change the way that we manage that, and then also engage with the assisted living providers and understand what's important for them. But I do think it's an important vulnerable population, and we certainly spend quite a bit of time thinking about how we can serve them in the best way and in this time of change, but realize just like the nursing homes, just as vulnerable and need that level of support as well, especially for some of those homes.
Yeah. Anyone else want to speak to this this topic of assisted living?
I think any time that you have congregate living, you're at risk for that drastic spread. And when you have congregate living with people who need care, and you're going to continually have multiple caregivers, it's a very challenging environment. And I think the elder care industry is potentially having to look at how they do things much differently than in the past. We in hospitals have always had a level of policy and procedure related to dealing with infectious patients. But now we're dealing with the potential for a caregiver to infect healthy patients, and it's the reverse, and how to deliver care safely in a congregate living environment, regardless of which it is a really a challenging conversation.
Yeah, I was gonna chime in and just say to what both of you were speaking to. I mean, even in places like Sweden, who have taken a completely different approach to trying to tackle the pandemic, where they've said, listen, everyone elderly and who have pre-existing conditions, stay home as much as possible. All the young, healthy people, get out there. Hopefully we'll get to herd immunity. They're still seeing these outbreaks in the congregate living facilities. And exactly to what you said, Mo, it's that the staff still need to go home, and they often contract the disease and come back and bring it into the facilities. So I think it's something that's not unique to Arizona. It's not unique to the US, but this is something that the entire world is trying to grapple with.
Marcus, I want to turn to your slide next. It's a stark one. It's a little bit of a surprise. Tell us what we're looking at here with your slide.
Sure. So this goes back to me being a data guy. So one of the things we do at Vitalyst Health Foundation is we really pay attention to access to health insurance coverage throughout the state of Arizona. And so Medicaid is well known as a counter-cyclical program. So anytime that the economy dips, Medicaid enrollment goes up. What we're looking at here in the orange line are unemployment claims. We've heard plenty of stories on the news. We probably know plenty of people who have unfortunately lost their jobs due to the COVID pandemic, and are filing for unemployment. Unemployment claims in Arizona have skyrocketed, as expected. We would also expect that due to the nature of employment being tied to health insurance coverage in the United States, that health insurance coverage would also be lost by a lot of people. And so therefore people would be out there searching for new sorts of health insurance coverage because they don't have it covered through their employer anymore. We are not seeing that, at least with access with Medicaid enrollment right now. In the blue line, you're seeing new access applications each month that have been approved. In December of 19, pre-pandemic, it looks almost the exact same as it did in April. And Access recently published data for May a couple of days ago, and it's still a flat line. The National Association of Medicaid Directors, all the different Medicaid directors, their association, they actually put out a publication a couple of days ago that acknowledged that this is a national trend right now, that it's not just Arizona, that they're seeing a delayed uptick, a potential uptick for access enrollment. So it's a confusing phenomenon that we're observing, and we're anticipating that there will be an uptick in hopefully the near future, but we're just not seeing it yet. And to go back to the conversation about health disparities too, this ties right into that. We know that certain communities are far less likely to have health insurance coverage than others in the US and in Arizona. And if folks are not getting the benefits that they are entitled to right now, like if you lost your job and you're eligible for access, but you're not getting it, it means that those disparities are just going to be exacerbated by this pandemic, as we see in so many other sectors. So it's something we're paying attention to. We're trying to work with Access, along with the Department of Economic Security, who administers the unemployment insurance, to see if there's opportunities to connect the two together a little more seamlessly. But it's quite the conundrum right now.
I know we've got hypotheses only on this. I can come up with a couple guesses. What are your guesses, Marcus, on why this is lagging so much?
Yeah, it's a great question. The first thing that comes to mind is that there's a kind of a Maslow's hierarchy of needs thing occurring, and understandably so. You lose your job, the first thing you're thinking about is, oh crap, I have to have some sort of income for me and my family. I need to go file for uninsurance, for unemployment, and get unemployment claims. The second thing is, we got to put food on our table. So I'm going to get signed up for SNAP benefits, for food stamps, commonly known as. And then somewhere down the line, you realize, or you start thinking about, we need to get insured again. We need to get health insurance coverage. So that's the first thing that comes to mind, is that there's probably this kind of delayed hierarchy of needs that's occurring. So yeah, but I defer to others too, if there's any insights there.
Yeah, Lori, what would you hypothesize are some of the reasons for this gap?
Yeah, I have the same thoughts that Marcus does, but maybe in addition, just thinking through to your point, are some employers continuing on the benefits? They haven't run out yet. So now in June, all of a sudden we see an uptick, but this has been extremely surprising for us as well, and not what we anticipated. And I know Access in our calls has asked, what other theories are there? I've seen papers written on it. I think to Marcus's point, across the country, everyone's trying to understand it, but I still believe it's going to happen. It's a matter of time, and it's just that there's the timing between unemployment claims and Access may not be as tightly understood, as before. I know even Access has tested their system to make sure there aren't problems from that perspective. Is there anything else going on? And haven't seen that. So it's definitely something that we anticipate, but just a longer time lag than first anticipated.
Yeah.
And the fortunate thing is that Access is available to everybody year round. Well, if you qualify. In terms of people qualifying for the marketplace, so say you lost your job, your spouse still has some income, so your total family income drops and you now qualify for marketplace coverage. You've got to apply for marketplace coverage within 60 days of losing your job or losing your health insurance coverage. So for people who lost their employment at the beginning of the pandemic, they've likely passed that 60-day deadline, which kind of leaves them in a no man's land for finding health insurance that's affordable.
Len Kirshner had said, I asked his question earlier, he said, don't worry, Marcus, the tsunami's coming. I want to ask another question from Karen Salins here in a minute, but first I want to switch to your slide, Mo, as a preface. Why don't you tell us about what you are thinking about when you bring this slide to the conversation?
Yeah, I'm going to shift away from the data points, and while we in healthcare all look at that quite regularly, there's one of the learnings that I've had is that we need to relate with our team differently. And when I saw this slide, I thought it sort of evoked emotion that could really speak to what maybe all of the population might be feeling, that maybe there's some emotion that would stir up in anyone who saw this. I think we'd all agree we're tired of COVID. And then after the recent weeks, the things that have been happening in the last couple of weeks, I think it speaks to that as well. It's just, this could be despair, it could be prayer, it could be disappointment, it could be that someone is tired. But that's why I selected this slide. And I wanted to talk a little bit about our staff and what they have experienced in this pandemic. And, things just really changed in our environment. And you've all undoubtedly heard that there wasn't enough PPE We weren't able to source PPE for quite a period of time to be able to protect our staff. So they'd been preparing for a surge that thankfully to this point hasn't come, but may still come into the future. And they knew that contingency plans for PPE had been put in place and that we wouldn't be able to protect them in the same adequate ways, more than adequate in many ways that we had in the past. And they'd seen patients deteriorate literally in front of their eyes. In a couple of hours, a patient presented to us at one point in time with GI symptoms and a productive cough with a history of lung disease that didn't look like COVID early on. And within literally a couple of hours, that patient was intubated and sent to the city and deteriorated very quickly. So with that experience on hand, they could also see how quickly patients could go from really being stable to life-threatening in just a matter of a couple of hours. And they'd seen all these news reports, as we all have, about really horror stories that have been experienced in other states and countries. And weighing on them all of this, with all this knowledge, we also have no negative pressure areas in our facility. So that's, for those of you that may not know what that is, it's just a way that air moves differently to protect the staff and to protect the spread of infectious disease from going into other areas of the facility. We have none of those here in this facility. So they were frightened and anxious, really waiting for the unknown or the bad to hit, some so much so that we referred them to our employee assistance program for counseling or other kinds of professional help. But in spite of all that, and in the face of all that, they were innovative. We had a physician come, one of our ER doctors that also works in a larger facility, shared some information about a way that might work to protect staff when intubating a patient, which is particularly dangerous in terms of the spread of infection. And our staff went right to work. They built a box out of PVC pipe and went to the dollar store and got rain ponchos to drape over the area where the infection would most likely be spread during an intubation procedure. And they practiced. And so they made, they were innovative and they were able to really be creative and prepare for those times in spite of the fear and in spite of the anxiety. And they were resilient. They just kept coming back, and they kept being willing, regardless of what happened that day.
It's a good reminder that this is both art and science in medicine these days. I want to go back to this telehealth question that Karen posed, and since we've got you on the spot here, Mo, Karen Salins had asked, are there about other barriers in the rural areas that prohibit telehealth that we should be aware of, besides things like patient comfort, technology, or provider revenue? Maybe those are cultural. Are there just other things that maybe the broader community can help support or address to drive telehealth to support you all?
Really, I think technology is a piece of it. And besides all those things that you mentioned, I can't think of anything off the top of my head. I do think sometimes in rural areas, technology is a problem. We don't necessarily always have the internet connection that is necessary, for instance. And so from a patient perspective, they may not have that available to them depending on how far out they live. Yeah. They may not have enough bandwidth, things like that. But there's also that clinical element that is a barrier. Some patients just need to be seen in person and need to be touched and listened to in terms of their body to be properly evaluated.
One thing I think this pandemic has reminded us of, though we haven't seen a lot of talk about it, but we've had a gap over the last number of decades where now there's something like, depending on how you measure this, something like 7 administrators for every 1 physician that provides care. And I think this has really refocused our attention on the importance of the caregiver and the provider and the physician and the nurse, and not just the folks that make the system run, but the people who provide the care directly. Marcus, I want to ask you a follow-up question from Jim Hammond, who asks about the connection between unemployment benefits and access eligibility. Are there things that inhibit access eligibility because of the $600 extra federal unemployment support, or other benefits that maybe the access Medicaid calculation for eligibility hasn't adjusted to yet?
I haven't heard of any specific barriers to that. My sense is that part of this is folks are going to DES. DES, understandably, is completely overwhelmed right now with the amount of demand, and it's a large bureaucratic agency, and it takes time to get things changed from a policy angle, and so there's probably some opportunity to work with the team at DES to see what kinds of things could be done even on the back end with DES and UI application data to do some presumptive eligibility type things for access, or even, you're filling out this Medicaid or SNAP benefit application. Would you also like to fill out UI? Or you're filling out UI. Would you also like to check this box if you would like to apply for Medicaid? But those sorts of solutions that seem simple on the face are just heavy lifts in a large agency like DES. So,
yeah. I want to move to our fifth slide and get your take on it. This is a slide that comes from the Institute for Health Metrics and Evaluations. It's an organization that's doing a lot of modeling of the growth of this disease. I think we know now that models can vary widely, and they are best guess targets about the future, always hard to measure. But that at the same time, we have more data now than we did 3 months ago about how this is actually impacting families. The slide or the graphic on the left is the number of daily deaths per capita per 100,000 folks. You can see Arizona is relatively low. That is as of 2 days ago. You can also see that 6 weeks from now, while this appears under the IHME model to slow down in terms of deaths per capita, that Arizona will be among the highest death rates per capita, still not anywhere close to what was initially projected. But I think what this shows is that this disease will continue to take a non-linear course. It will still move all over the place. On Monday, there were 127 new infections in Arizona. On Tuesday, there were 1,100 new infections. On Wednesday, there were 970 new infections, according to Worldometers. So the numbers all over the place. Let me ask you three, and Lori, you can start. What are the data points that you have come to trust, that you have come to look at and think about as you're trying to predict the future, recognizing that's a fool's errand and impossible, but yet we still have to try to do it? What are the data points that you're looking at to try to figure out how to lead your organization?
Yeah, it's such an important question and so interesting, and even for me, a little bit concerning on some of the data that we've seen just this week, knowing that could reflect some of the opening up. And I know I've heard some discussion too that we probably haven't seen the full impact of, for instance, Memorial Day and some things like that. For us, we certainly rely on the ADHS website and the data being reported there as probably our first look. But two, as we've gotten our own data on our own members, been able to understand that a little bit better, we're starting to see some claims. We can start to try to understand that, even break that down between some of our populations to understand that as well. I know when you look at this, it's certainly pretty concerning. I know for a while I was turning to that University of Washington model and still look at that once in a while to try to understand where things are going. And to your point, an estimate, but fascinating that they have Arizona and it looks like Colorado as pretty significant impacts going forward, along with California. So certainly something that's concerning. And to your point, we also still try to, are just starting to get an understanding both of a second wave potential that we see, and then secondly, are we seeing people present now that have are now maybe worse off than they would have been had they gotten some of that preventative care. So those are certainly really important metrics for us that we're focused on. But yeah, I think the models we're looking at, and to your point, change often, but certainly this is a concerning view.
Yeah. Mo, how about you? What are the data points that you have come to trust through this, or the things that you kind of look to first?
Certainly the models. I definitely looked at the models early on, especially. I would look at them consistently so that we could know a little bit about what to expect, or at least someone's scientific approach to that. More recently, I have been looking at those daily new cases. You mentioned earlier the numbers. The numbers have spiked at an alarming rate, in my estimation, over the last week. And I too imagine that has to do with opening up the state and Memorial Day. And then we internally look at what do we need to do differently here. We've taken some measures internally to respond to that and be prepared for that differently than we had in the past for a number of different reasons. But it's definitely concerning, and I continue to look at those data points. And also, I think it's important for us to model good behavior in the community. As healthcare providers, our team needs to model the things that help to reduce the spread. And so we encourage our staff to look at that and think about that, and think about how they are, what their human behavior is outside of the organization as well.
Marcus, how would you measure the community's response? So everybody, government, non-government, public, private, how would you measure the response towards the homeless population, towards the least among us, and how the community has supported that population? Philanthropic organizations are often looking at gaps and how they can fill them. So where have you identified gaps in that process, and has it, what are your takeaways from that observation?
There's no easy answer, obviously. I will say that I personally was impressed with how quickly, once we realized how intense this was going to be, the local health departments, local municipalities were trying to focus in on which populations are most at risk, and let's throw resources there. So I know, like, the city of Phoenix was really focused on the human services campus. We were involved in conversations with various commercial real estate owners to figure out, are there vacant properties that people who don't have a safe place to be can go into? The plan was, with the old St. Luke's Hospital in downtown, or near downtown, to turn that into a COVID unit. Fortunately, we didn't have to, or we haven't had to use those resources. But maybe it's because of the circles that I run in. I think there was a heavy focus on how do we help to benefit those populations that are most at risk of the spread of the virus. And in that same vein, obviously we saw a ton of news stories and a lot of energy going toward our tribal population. In terms of numbers that I look at, it's looking at the prevalence rates up in Apache County, up in Navajo County, which are 10 times that of Maricopa. Yes, Maricopa, the great state of Maricopa, has far more cases, but the density of cases up in northeastern Arizona is striking. So those are some of the things that we're paying attention to.
That was one of the most amazing stories to come out of this, in my view, is the contributions from the Republic of Ireland to the Navajo Nation to support the Navajo Nation through their time of COVID, whereas the Navajo Nation had supported the Republican effort in Ireland 150 years ago. Really cool cross-Atlantic, cross-cultural experience. We're winding down. I want to ask each of you just sort of your thoughts and encapsulation, I think, of this conversation, but also just what you've been paying attention to over the last number of weeks and months. if you were in a room with Governor Ducey and a number of legislators, and they were like, hey, we're going to get back together in special session and we are going to learn from this COVID experience. Lorry, what would you have us do? How would you answer that question?
It's a great question. Absolutely, to your point. I think for all of us, we know we're not going to go back to even February of 20, right? 2020 will be a year certainly to forget, but at the same time will really have an impact on really the way we deliver care and the way we think about things. What I would encourage, and I know we've been partnering with the other Medicaid plans and access as well, is what have we learned from this, and what do we not want to just say, oh, it's over, let's go back to how things were. Let's really think about the learnings and some of the real, positives, if you can say that have come out of this, and how do we change policy and the way we think and kind of manage care going forward. So for me, I would encourage him just to really take a hard look at what's happened and what's evolved in such a short period of time.
Yeah, good. Mo, Governor Ducey calls you. He's got some legislators on the conference call, and he asks, what should we do in the special session to learn from this experience?
Gosh, I would I echo what Lorry has to say. I think I would say, maybe we need to wait. I think we need to wait a little while and really evaluate the entire experience, because it's not over yet. And what is it that we need to do in that special session on an interim basis to help mitigate the consequences of the upcoming several months? What can we do as we anticipate the flu season and potentially higher cases, and how can we work together to save lives in that period? And then a year from now, 18 months from now, whenever the time is right, to go back and say, there are definitely things that we could look at in terms of preparing our healthcare institutions differently, or staging supplies differently, or any number of things that come to mind that I think we will have even more insight into in a couple of, within the next couple of years.
Yeah, good. Marcus, give me a legislative agenda, the governor says, for this special session. How do you respond?
The first thing that comes to mind is something that Will Humble at the Arizona Public Health Association has raised in recent weeks, which is we've had a number of great executive orders that have been enacted to try to deal with the spread of COVID-19 and its aftermath. One of those executive orders kind of hampers the ability of local municipalities to enact policy outside of what the state is doing. As we're seeing, especially with different rates of infection across the state, this virus is not affecting every jurisdiction in the same way. Some jurisdictions are not being affected really heavily, others are being heavily affected. So if there's a way to modify the executive order that has historically pulled away authority from municipalities and other local jurisdictions, and give them the authority to make policy that can either reopen their communities as appropriate or start to ratchet things back down as appropriate, I think that would be really, really important to do.
Yeah, great stuff. And I'm reminded through this conversation just the complexity of healthcare reform, and then this overlay of the challenge of COVID, both operational and financial, and then the social context in which we all live, and the protests and the deaths and all of that we're grappling with as individuals. We posted at our site, stateofreform.com, the transcript and an audio link to Robert Kennedy's speech on the night of Martin Luther King's assassination on April 4th, 1968. It's a short speech. I'd really encourage you to listen to it. One of the takeaways from that is as applicable to our social construct and situation today as it is to health reform, which is in America, we have to try harder than other nations. We have to work harder together to reaffirm the common ties that bind, to solve the problems that are in front of us, but that we should not lose hope that we cannot solve these problems, because we can. And as a former governor of Oregon, John Kitzhaber, one of the leaders of health reform in the United States, says there is no survival value in pessimism. So keep keep working. Lorry Bottrill, CEO and president of MercyCare of Arizona. Thank you for being with us. Marcus Johnson, director of health policy at the Vitalyst Health Foundation, and Mo Sheldon, the CEO of Northern Cochise Community Hospital. Thank you all for being with us, and for the 120 plus folks that joined us today or were registered today. Thank you for being here. We're going to send you an email to ask you about how we did. I'd love to get your few minutes of time and attention to let us know. I'd really appreciate it. With that, thanks for watching. We'll keep these going if you'll keep watching. Take care.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.